Good afternoon, everybody, and welcome to the Structural Challenging Case Competition. Honored to be with my panelists today. I have Dr. Rahul Sharma and Jonathan Schwartz, and William, she will be here as well, and we will be walking through this session. Just a quick reminder, it's a 5 minutes for the case presentation and 5 minutes for discussions. So, try to stay on time in case you're a fellow and you want to transition to faculty. When you give a talk as a faculty, they cut you off at 5 minutes. We're going to try not to do that, but try to keep it at less than 5 minutes for, just to be able to go through everybody. And with that, let me introduce our first speaker, Weston McCowan, who's going to talk to us about complex TMVR valve-in-valve case.
Afternoon, everybody. Make sure I've got this right before I dive in. Okay. So I'm Weston McCowan. I'm a newly minted PGY2 at the University of Kentucky. As you can see, if you look at the PowerPoint working down the chain of command there, I'm at the very end as the intern who was somewhere in the operating room for this case. And we initially called it a TAVR in the mitral position to hook you in, and then changed it. I have no disclosures outside of I'm a PGY2 who's going to try to explain this to a bunch of fellows and cardiologists. So our case presentation, this is a 57-year-old female with a past medical history. She's ESRD on HD. She was transferred to our facility for evaluation with severe mitral stenosis. We were initially told a gradient of about 31. They sent her here for CT surgery, eval. Most notably, she had a BMI of about 15. Other pertinent CV history, she had a bioprosthetic mitral valve placed in 2012 due to endocarditis. By our TTE, we found she had a mean mitral valve gradient pressure of 27 and a valve pressure half time of about 255 milliseconds. As you can see, we confirmed it on our echoes here, looking at her gradient, and again, not much flow coming out of that. Clinical challenge here for someone who's already had a bioprosthetic valve. We ultimately reached valve failure, and unfortunately she is not an operative candidate. Due to her ESRD, her malnutrition, she likely would not survive any sort of open chest cavity procedure. Our heart team sort of got together and decided a mitral valve-in-valve replacement could be feasible. What I didn't show in this is she had a CT scan that with mapping showed she would have minimal to no left ventricular outflow obstruction based off the new placement of a sapien valve. We discussed it thoroughly with the patient, risk and benefits based off of her pre-existing health conditions, and she decided to undergo a valve-in-valve. A little bit of research just to back us up here, most prominently looking at the JACC article from 2016, 92% had functional improvement. Back to like an NYHA class 1 to 2 after 30 days, and kind of why we proceeded on with this procedure. We did a pre-procedure TEE, get the images going here, really just to confirm, looking at our 3D mapping of the valve as well, just not much movement there. So I'll fumble through the intervention here. We use right femoral venous access. We placed 2 8 French sheaths. One was for the transvenous pacing wire. The other one is where we did the most of the work with initially an SL1 transeptal sheath. And under TE guidance, we did a transeptal puncture. We also, at this point, when I left out, we anticoagulated with heparin at about 300. Looking at the images here. And then the SL1 the transeptal sheath was exchanged with our Agilus steerable guide sheath, and we advanced toward the existing valve. We then advanced the pigtail catheter into the left ventricle, exchanged it for a Safari guide wire. At this point, we also serially dilated the balloon to dilate the septum to about 14 millimeters to promote our valve passage. You can see it here. And then I'll just get these two going. This is our Sapien 3 Ultra TAVR, our 26 millimeter valve. We can see advancing it here and then ballooning it. We RV, or rapidly paced at 140 beats per minute. I'm sorry, there's a I'll try to look around it. There's a smart device notification here. Once we had the hemodynamics confirmed, we deflated the balloon. And then our post-TE imaging here shows much improvement, a lot of valve mobility. And then again, just confirming our results. Trying to look around the smart device here, but gradient jumped down. It looks like a mean pressure of around 3 and a max around 6 after the intervention. Now the next issue, we have to fix the hole we made. Typically these may or may not be fixed depending on how much shunting is present. Unfortunately for her, there was a significant amount of shunting, hypoxemia. So we used a 12 millimeter amplets or atrial septal occluder to close it. And we'll show you here on the next slide our closure technique. And then here's our result with no shunting afterwards. So conclusion, learning points. This actually says DAP, but she, I believe, was anticoagulated on warfarin. She was discharged on post-op day 4 to 5. Follow-up at a month, she was down to NYH class 2 to 3 for her symptoms after initially being a 4. Learning points, obviously for me as an intern during this case, everything was a learning point, but in general, this is a possible or a viable solution for people who have these failing bioprosthetic valves that were placed, years ago. And I think importantly for this patient, this was maybe we can't guarantee a lot of change in mortality, but ultimately a lot of benefit to quality of life, at least in the interim. She was able to go home, back to rural Kentucky, hold her grandkids for the holidays. And I'll take any questions. Thank you.
Thank you, very nice presentation, and please excuse me for being a little bit late. Yeah, very nice presentation. I'm interested to know, you plugged the transeptal hole at the end with a closure device. What's your kind of take on the timing of that? I mean, do you think is your center do it sort of routinely at the time, or do you kind of give patients maybe a few days to see if they truly require it? I guess it's more hardware in the body, and we like to believe that many of these holes either aren't clinically significant or sort of start to get smaller over time. And certainly, if someone's lying flat with heart failure, they get rapid pacing. There's multiple reasons for them to be acutely hypoxic. So what's your kind of thinking about timing?
Absolutely. So I think typically at our university, we usually give them some time and make sure there's no significant hypoxemia or any other developments with the shunting. But I think just based off of her comorbidities and the risk of putting her under, again, any other sort of anesthesia, they decided to close up at the time.
Yeah, that sounds very sensible. I think, with a sick patient having a lower threshold seems very sensible. Thank you. Nice presentation.
Wes, this is very nice to see a second-year resident presenting a structural case. Congratulations, you did a wonderful job. And, it's not an easy case, but also to see that the knowledge of what is available there in terms of, valve and complex intervention penetrating into our, internist and training programs is also really, really nice. So I really thank you for your interest, because we struggle sometimes having the cardiology community understand that there are those options available for, for patients. And I'm very interested in how were you involved in the care of this patient? Like, was it somebody that you've taken care of the medicine wards, and you were interested in following her care? How
Yes.
How did it happen?
We have a cardiologist floor service that the interns rotate on. I admitted her on a night shift and cared for her for about 2 weeks. She was actually, by the time I went off service, the day after she went into the operation, of course. So I was nearby. I kind of came back just to sort of peripherally see how she was doing. But yes, I followed her very closely for several weeks until we finally proceeded with the procedure.
Were you in the procedure?
No, I was sort of around the cath lab, but not in the cath lab. We don't even have a suite where I could view. I was just sort of like pacing outside, just wondering how things were going.
Very nice. Again, I really echo Firas's comments. It's great to see you get involved at this stage in the game. I think a lot of times internists don't even know the possibilities. Like, this is someone who easily could have just been written off and say, well, we can't do anything, and that's that. So now it's great that you can share the knowledge. Not to criticize at all, but I'm just wondering, end-stage renal, BMI of 15, was there discussions with palliative care involved, or how'd that go?
Yes, I think some of this, what we learned is that she was severely symptomatic. She had bed sores, the BMI. She wasn't getting out of bed largely because she had significant orthopnea, dyspnea. Like, she couldn't get up to cook, and rural Kentucky, there not a lot of access to stores, fast foods, things like that. So we learned that a lot of her functional decline was probably related to the valve issue. So whether this repair was truly more of a palliative repair, in a sense, was sort of the lens that we looked at it through, because, again, with her comorbidities, we may not have guaranteed her any sort of prolonged life or success after this, but we do think, at least in the short term, it gave her some functional improvement. And she was okay with that, and the family wanted that. Hopefully that answers.
All right, so move on to the next speaker. Thank you so much. So the next speaker, keeping the same theme, is going to take it an inch, probably higher, and say it's going to be a complex TMVR valve in valve. So I see some level of complexity here. We have Kishor Khanal.
Good afternoon, everyone. I'm Kishor Khanal, one of the cardiology fellow at Memorial in Florida. Thanks for this opportunity to present this case of valve-in-valve transcatheter replacement, and thanks to Dr. Khalili for his tremendous help.
Just press the main. Yeah, exactly. It takes a bit of time.
Okay, so no relevant disclosures. And this is a 76-year-old gentleman who presented with NOHA class 3 symptoms. He has known history of cabbage, had a surgically replaced mitral valve, reduced LV ejection fraction, and recurrent left atrial thrombus and splenic infarcts despite being on anticoagulation. So these are the initial TE pictures. He was found to have bioprosthetic failure with severe mitral stenosis, initial gradient of 8 millimeters of mercury. This was the left atrial appendage. You can see some spontaneous echo contrast, but there was no definitive organized thrombus based on the contrast imaging. So based on his symptomatic severe mitral stenosis and STS mortality being high, so we decided to go for a transcatheter replacement of the mitral valve. This is the pre-procedural planning with the CT scan. We fitted 29 millimeter valve and the new LVT area of around 647. So the first clinical challenge we faced was, this is the TE on the day of the procedure. So he had a recurrent left atrial thrombus. Just to let you know that the warfarin was not held for the procedure just because of this concern. So for the resolution, we went ahead and placed spider filters just to prevent the risk of stroke. So the first thing, we went ahead with the transeptal access. On the TE, he had thickened septum, probably had a repair with his septum during the surgery or some fibrosis. So we were anticipating some challenge there. We started with a 12 millimeter balloon, dilated it, and then we did the mitral balloon valvuloplasty using the same balloon. But despite that, we tried multiple times, couldn't cross the septum with the delivery device. The valve couldn't be crossed. We upsized the balloon to 14 millimeter, and still we were unable to cross. We suspected it due to quick septal recoil. Actually, I have some notification I cannot get ahead. Okay, here. So at this time, we decided to use balloon-assisted tracking through the septum. So what we did, as you can see in the first picture, despite dilating the balloon, there is a significant waste around the septum, showing how non-compliant the septum is. And after fully deflated balloon, you can see the picture on the right. So once the balloon was being deflated, we tried to manipulate the device, and then we were able to get through the septum with this balloon tracking system. So next challenge we faced was that the device was in the left atrium, but we were unable to place the new device into the mitral valve plane. So despite multiple attempts, we were unable to do that, and at one point we accidentally lost transmitral access, and the whole system had to be out, and then we had to repeat the whole procedures again. So at that point, we decided to get some support from the AV loop, so we created an arteriovenous loop. You can see the snare there. And we protected the aortic valve using a long sheath to protect it from the wire. There was significant recoil already in the septum again. That's why we had to use the balloon-assisted technique again to go through the septum, the whole process again. So the problem is, despite the support from the loop, we were unable to cross the valve even at this point. We tried multiple manipulations. So what we decided is maybe we can use the same balloon-assisted technique to cross the mitral valve. So on the picture on the left-hand side, you can see that we are inflating the balloon and while the balloon is being deflated, we are trying to manipulate the delivery device so that we can get it into the mitral valve plane. And on the right-hand side, the device is in place, and then the body wire has been withdrawn now. So at this point, we were happy with the position of the device after some manipulation, and we deployed the valve under rapid pacing, and we were happy with the position. As you can see in the picture on the left-hand side, it was difficult and prolonged inflation. Than usual, we thought it could be due to a kink in the shaft, and then we did some post-balloon dilatation as well after we placed the valve. So this is the final results. You can see the TE image on the right. We were quite happy with the position. There was no paravalvular leak detected. The final transmitral gradient was about 3.5 millimeters of mercury. There was no significant aortic valve injury noted at the end of the procedure, despite all those manipulation. Interestingly enough, the left to right interatrial shunt was very minimal, despite all those balloon inflations and manipulations. So to add a little more to the case, the patient developed transient complete AV block during the procedure, so we decided to put a temp pacer and left it in place after the procedure. Just to note, he had underlying bifascicular block to begin with, so given his cardiomyopathy and this complete heart block, we decided to go with a CRT device in him. And then, so just to reiterate some key points, procedural planning is very important. Some anatomical challenges should be kept in mind to go through the procedure, and although not so common with the TMVR, when compared to TAVR, complete heart block can happen, which in our case could be due to the AV loop and manipulations, but one needs to be mindful of that. And that's all I have. Thank you.
Thank you. Very nice presentation, obviously a challenging case. I'll ask my colleagues here, do you have any other suggestions when you can't cross a transcatheter mitral? Rahul, you gave a great presentation about a complex TAVR case, but when you can't cross a mitral, other than dialing some volume in the balloon, do you have any other suggestions?
Yeah, so what I've done only once on the mitral side is to snare. So basically, I'll put a pigtail into the LV and bring a pre-shaped wire, Safari, Confida, whatever your wire of choice, snare the pigtail before the wire exits the pigtail, and then walk the pigtail out. Now you've got a snare on the wire. And it usually is enough to pull. I've only had to do that once, whether it's stenosis or usually it's regurgitation. It's very rare to have to use the kind of support techniques. And kudos to you and your attending for like weathering through this TMVR from hell. But I can't help myself, I have to say this. I would never have attempted this procedure because of the left atrial appendage thrombus. Now, it's a mixed bag, right? And I don't mean to critique. I mean, in the end, I assume your patient did well, and again, congratulations. But there's so much that could have gone wrong, whether you had spider filter wires in the carotids or not. And all your efforts could have just been totally for nothing had even a 2 millimeter fragment of that thrombus embolized somewhere. So that's the challenge here is, juxtaposing the complexity of this case, the tremendous techniques and effort that you all went through, even after losing LV access once and then having to do the AV rail, all those things. And yet, what if, there was a stroke when this patient wakes up, or if you had seen a clot in transit? So that's the challenge. And in the environment in which I work, which is a very much commercial on-label environment, because I don't work at an academic center where we can do off-label things, I don't think this case would ever have even been allowed to be done because of the thrombus. Now, there is a caveat to that. There was a case where the patient had a thrombus in the tail of the left atrial appendage. It was an anterior chicken wing, and the rest of the appendage was completely clear. So I put a Watchman in that appendage. This was a few years ago before we had Amulet. I put a Watchman in that appendage, and then we went ahead and did the TMVR like 2 weeks later. The interesting thing, though, is that in this case, and in many cases like this, after you do the transcatheter mitral, there's dramatic reduction in the spontaneous contrast and obviously in the gradients. So you're doing something that is helping the clotting process by replacing the valve, but when there's a clot already there, it's just really bad luck for the patient because there's all this risk return. And then I've heard of people doing things that I have no experience with, like taking a Watchman upside down in the aortic root and using that as basically a filter. Of course, that's off-label and extremely expensive, and I don't know if it even works. So there's all these other things that people have tried that I've heard about or seen in case reports. But yeah, when you have an LA thrombus, it's a hardline contraindication. But I'm assuming your patient did not have a stroke or an embolic event and that she did well?
Yes, he did well, and we followed up in 6 months, and everything went well. So that's
did
the discussion.
Did the thrombus resolve?
So we don't have a repeat. We are planning to repeat,
Okay.
do a repeat TE, so we don't have the reports, but no clinical findings of stroke.
Yeah, it's incredible.
Thank you very much. Nice job.
Thank you.
Our next speaker is Dr. Khan, who's going to discuss hypoxia in interatrial shunting and the diagnostic challenge. Thank you, Dr. Khan.
Good afternoon, everyone. My name is Zamrak. I'm one of the vascular medicine fellow at Cleveland Clinic. When I saw this case, I was working as a hospitalist at Cleveland Clinic. I don't know how to move this thing off. Yeah, okay, good. So I have no conflict of interest here. Case presentation. So we start with a case. She's a 63-year-old woman who was admitted for evaluation of hypoxemia. In regards to our past medical history, she had non-ischemic cardiomyopathy with improved EF, bicuspid aortic valve with mild stenosis, and hypertension and hyperlipidemia. She was admitted from the office for evaluation of hypoxemia. She was largely asymptomatic. She required 2 liters of oxygen at rest and up to 6 liters with exertion. And we confirmed hypoxemia with ABG, which showed that she did desaturate to 86% on ABG on ambient air. So common things being common, we first started with chest x-ray, which was unremarkable with its CT chest, which obviously did not show any pulmonary embolism, no parenchymal lung disease. So all the obvious pathologies will rule out with these basic imaging modalities. This is chest x-ray, this is CT chest. And then we proceeded with an echo, which showed she had normal EF and she had mild AS with moderate AI. And then the echo showed that she had PFO, which was confirmed with TE as well, both by saline contrast and Doppler imaging. Cardiac MRI confirmed the PFO, and it also showed she had a small shunt of ratio of 1.1. Then we went ahead and did the right heart cath, which showed she had normal pressures. So here is where the challenge began. Could this patient's hypoxemia be caused by exercise-induced pulmonary hypertension? So we went ahead and did a right heart cath with exercise, which showed that she had normal hemodynamic response. And then the next question was, is PFO the cause of shunt? So the team was kind of skeptical about it, so we went ahead and did an ICE imaging, which showed that she had a small sinus venosus ASD with a positive study. These are the images. This is ICE images which showing that there was a shunt from right to left side. The clinical challenge, does this sinus venosus ASD defect needs treatment? Technically speaking, usually there are few indications where the shunt needs to be closed. Few of them are when the RV is enlarged or there is significant pulmonary hypertension, when there is shunting left to right, or which usually is signified by the ratio more than 1.5, or if there is a paradoxical thromboembolism. So our patient did not have any of those symptoms or indications for shunt closure. The one thing which we did with, at the time of right heart cath and ICE imaging, we did do a shunt run which showed that there was a drop in saturation moving from pulmonary veins up to the aorta. So we had a multidisciplinary meeting, and the decision was made, since that this patient actually had no other symptoms that would explain her hypoxemia, we went ahead and decided that we should do the shunt closure. The next question was, should we do a surgical approach versus a transcatheter one? Traditionally speaking, surgical approach has been preferred over the transcatheter one, but there are a few recent studies where they have looked at the result outcome of transcatheter closure versus surgical. The one recent study which was published, they looked at the efficacy and the treatment outcome of surgical approach versus transcatheter, and they did find that there was a good response in regards to transcatheter approach when the selection of the patient was appropriate. So given this patient had a small defect, we went ahead and did transcatheter approach while ensuring that she had patent right upper pulmonary veins. We decided to go with a 20 mm Gore septal occluder device. These are a few of the images which were taken during the procedure. This is the Gore septal occluder, which is going towards from right side to the left side. And these are the other images which we are looking at. The device is occluding the LA and RA. And these are the images we are looking at the bubble study after the device was deployed, which shows that there was no shunting. And the case outcome, patient did well after the procedure, hypoxia resolved. She had a follow-up echo which showed that she had no shunting on the follow-up echo, and she continues to do well after one-year follow-up. So the key learning objectives for the team were the sinus venosus ASD could be a challenging diagnosis. Sometimes it could be missed because the defect is so small that it could be missed on the routine images like MRI or even echo or even MRI. So I should be considered. And right to left shunting could be seen even in the absence of significantly elevated pressures on the right side, which means there are some other etiologies which could lead to the shunting. And the transcatheter approach should be considered as an alternative to surgical approach if the patient selection is appropriate, which usually means that there's a good window where the device could be deployed, and it's not associated with total anomalous pulmonary vein connection. So those are some of the patients which should be or could be considered for the transcatheter approach. This is the reference study which was recently published where they looked at the transcatheter versus surgical approach. And thank you.
Dr. Khanal, it's a nice case. Congrats. You had a good result there. I got to be a little bit devil's advocate here. So great that you can do this transcatheter, but was the patient a surgical candidate? Why would you not do surgical approach?
I think it was at the Cleveland Clinic, so they discussed this with the surgical team, and they felt like this is amenable to the transcatheter approach. Probably because the device, they did do an angiography where they wanted to make sure the pulmonary veins are patent, so it was confirmed before and after the procedure as well. They did have a room to do that, so maybe, otherwise there's no contraindication to the surgery. So we are just looking at the ease of approach and shorter length of stay, and the person with the procedures who was doing it, she was very confident that she can close it with transcatheter approach.
Okay, that's fair. And just a couple other things I noticed that I think are useful to point out. Number one, was the exercise right heart, I presume that was done with a bike on the table? Or do you know?
Mm-hmm.
So one thing to know with that, with patients that have PFOs, sometimes when they're supine, you won't necessarily see shunting there. So it sounds like she did have some hypoxia, but if it was normal, that doesn't necessarily mean there isn't shunting when they're upright.
No, we were actually looking at the hypertension, whether she had high pressures with exercise, so, because usually you would not see the shunting if there is no high right-sided pressure.
Sure.
So the reason they did it was there is like exercise-induced pulmonary hypertension. So the shunting was probably there, but the idea of doing this right-heart cath was whether the pressures increase when she actually does exercise.
Of course. The other part is on your shunt run, it turns out the numbers didn't really show that much shunting. A big part of that is where you're drawing your sats from, though. So in this case, you might have wanted to go a little bit closer to where the defect was, and there's a chance you could have seen some different sats, and that would definitely change your QPQS. So
They did it from the right upper pulmonary veins, and it was 95% on room air, and then the next was from the aorta.
great, let's move on. Thank you.
All right, thank you.
So next up, I have the pleasure to introduce Edoardo Zancanaro. He's going to be giving a presentation on valve and Tendyne, the first case of Tendyne outer frame degeneration.
So, hello everyone, I'm Edoardo Zancanaro, I come from Italy. I know what you're thinking, a surgeon between you, but don't worry, I promise not to bite you. This is a promise. So this is a really interesting case. This is a first in human Sapiendyne, as we call, because it's a case of Tendyne degeneration treated with Sapien. Okay, sorry, there was a problem. So I have nothing to disclose. So first of all, 63-year-old female with presented with dyspnea and peripheral edema, but the juicy part is the history. So let's start with type I dissection and treated with Bentel, and one cabbage and after pacemaker implantation. 4 years later, Evita procedure, so basically we replace all the remaining arch part with the dissection. In 1 year later, he underwent emergency TEER for endoleaks on the prosthesis, and of course, a thoracoabdominal aneurysmectomy for a dysfunction of the prosthesis. But finally, in 2019, we implanted the Tendyne for mitral regurgitation in a very complex patient. So, what else I forgot? Yes, STS and Euro score was quite high if you consider Euro score 2 with 7.5%. Okay, so we decided to perform a TOE and transthoracic, and what you can see at the Tendyne is a degeneration, but a particular type of degeneration. There is no paravalvular leak, there is no problem on the leaflet itself, but there is a problem in the outer frame of the valve. If you know a little bit about the morphology of Tendyne, you know that there is an inside part that it is the problem here. We do these two jets I pointed out. So just a couple of information: reduced left ventricle ejection fraction, also reduced right systolic function, and pulmonary hypertension. We perform CT in order to see the position of the valve and if was there other problem but the problem also for pre-procedural planning. And the valve was normal positioning, and we take all the measure for pre-procedural planning. Okay, the challenge is that this is the first case that never have been described of Tendyne degeneration. The patient was with high surgical risk, and we didn't have any leaks to close. This was the idea of our intervention, but let's go in details. So basically, the idea was to take a Sapien 3 Ultra, because we know that Sapien 3 Ultra has higher skirt-covered valve, and we put a PTFE struct around the open part of the valve, crimp inside the delivery system, and deliver that. Seems really easy, but it's not, because the problem is that the two jets was from the ventricle to the atrium, and so we need to close these two way of the valve. And in order to do that, we need a cover valve, so a customized valve, and also to be very distal, so go into the more onto the ventricle in order to cover the two green line. We have performed, of course, with transeptal procedure. We crossed the valve with Agilis because it was the only way to cross the Tendyne. And then we use two Safari wire, one in order to have a body balloon to help the Tendyne delivery system pass through the septostomy that we perform with another balloon, and then to have, again, a balloon in case the delivery system would have not passed the Tendyne. Fortunately, we just used the body technique for the septum, and then the Tendyne and the sapien went into the Tendyne pretty well. And let's see if any one of you will see the problem here during the implant. Yeah, maybe you see it. Yeah, I can tell you it's Houston, we have a problem. We just have to say Austin, I don't know. But we have atrialization of the valve. So we tried to post-dilate, but it was useless. So the other things, another customized sapien valve, and the procedure went exactly the same as before. And the final result is optimal with good hemodynamics, no leaks or no insufficiency. So this is the pre, this is the post with 3 of gradient. And the follow-up with patient is alive, no difference in the echo, and no hospitalization. So in conclusion, valve in Tendyne is feasible and safe. Preoperative planning is the key. Distally as possible as tips for you, and have a multidisciplinary team is a really important tips. Finally, I would like to say, to be honest, be prepared to have another sapien ready for another implant. Thank you very much.
That is not yet, I mean, I know your case was overseas, but the device that's not yet commercially approved but is already having degeneration.
No, actually is...
but you guys have access to it.
No, we have access because
yeah.
there is CE mark, so
Right,
we usually
yeah.
implant, we have like a good experience with Tendyne, actually.
Right.
We have a series of Tendyne implants.
My question was, the first sapien valve that you put in, do you think it atrialized because it pushed up against the tines, the narrowing in the ventricular side?
Yeah, absolutely.
So basically, it's almost like, I mean, correct me if I'm wrong, I don't know if this is going to sound silly, but it's almost like you have to use 2 valves because you're always going to have that, aren't you?
No, problem that this is, thank you for the question, this is a good point. No, I don't think that always, this is the first case, so I hope that nobody else will see that. I think that probably, yeah, the problem is that as you see the conformation of Tendyne, this can be a troubleshooting problem. I don't know if it is something that will be always present. Maybe we can change the size of the valve, I don't really know about it. But as I said, the problem to have 2 valves would be a great idea. I know that sounds really a lot cost effective, not a lot, because 2 sapien Ultra is like, it's really expensive, but yeah, this is the only way to cover this problem. Yeah, thanks.
So I have a question, and let's just say you go back to Italy and you have another patient now who has Tendyne at the same time and degenerate. How would you do it differently?
Thank you for the question. First of all, I would call Abbott saying we have a problem. Because, okay. It depends, of course, because there is also, was an outer frame degeneration that usually it's kind of rare. I mean, this is the first case, so usually you have leaks, or we have case of leaks that we have managed differently. If I would have the same patient, you need to remember there was a really high-risk patient with all this operation bent and this kind of stuff. So with the same, what I've done differently, probably, I don't know, to keep the rapid pacing more, because we have the atrialization immediately, so maybe another size of the valve, maybe bigger, so you have like more strength to cover, maybe to prolong the rapid pacing. That would be an idea. Yeah, this is also another way of seeing that, like to use that actually in order to prevent it. This is another way to seeing that, yes.
Well, that was a fantastic case. Thank you, and a wonderful presentation, Edoardo. Well, next we have somebody passed the duct tape, mitral valve repair with MitraClip and a plug, Dr. Sullivan. So just so you guys know, our task by the end of the session is to identify the top 2 presenter, and it's going to be based on the presentation and the case. And I'm not sure what happened. There's like a fist fight. Who?
Fight. I think it's fight to the death.
All right, perfect. Well, I'm going to run through that door after this. So, My name's Alex Sullivan. I'm a general cardiology fellow at Vanderbilt. Thank you for the opportunity to present this case. I have no disclosures. This is a case of an 83-year-old female who presented for evaluation of fatigue and shortness of breath that had progressively worsened over the last year. She initially was only having symptoms with exertion, but again, over that year developed NYHA class 3 symptoms. She had previously been evaluated and managed for symptomatic degenerative primary MR and had 2 prior MitraClips, an XT and an NT, placed 3 years prior to coming to our hospital, but was now having progressively worsening symptoms and worsening or escalating diuretic requirements. In between her prior clip and coming to see us, she had a TEE. You can see that she has jets of MR, this moderate to severe MR here. This primary jet is very eccentric, anteriorly directed, wraps the atrium, and you can see here on this 3D image really looks more severe. When she came to us, we repeated her TEE so we could get a sense of what we were up against. Again, you see this anteriorly and eccentrically directed jet. She has a second jet through this flail portion of the valve, and then it looks like the main jet is between the 2 clips. She had an EROA of 1.05 and a regurgitant volume of 59 mLs. A couple more images from that study, again, showing how eccentric that jet is. She had a transmitral gradient of 5 millimeters of mercury. And then prior to the case, when we ultimately ended up doing this, she had a mean LA pressure of 16 millimeters of mercury with a V wave up to 36 millimeters of mercury. So the challenge here is, this is an elderly, frail woman with recurrent or relapse MR after MitraClip. She's symptomatic, and how do you really go after this? So we opted to go after that flail A2P2 segment first with another XT clip. And so we went medial to the previously placed clips, grabbed the medial portion of that A2P2, those A2P2 scallops, and you can see that we had good position, deployed the clip, but in the bottom left-hand corner, you can see that there's a residual jet, and when you change the angle, you can see that intraclip jet, the quite eccentric one, is still there, and it's at least moderate. Her transmitral gradient at this point had only gone from 5 to 6 millimeters of mercury. She had been very symptomatic beforehand, and so we opted to try to treat this intraclip MR, and really didn't think it was feasible to do another clip, so we selected an AVP2 plug and went after that. Here you can see the plug being positioned, positioned in between the 2 clips. The ventricular disc was exposed, and then as the central disc was exposed, it was pulled in between the 2 clips. You can see in the top right-hand image that just prior to deployment, there was minimal residual MR. And then the final result in the bottom left and bottom middle, you can see that she had trivial to mild MR after the plug was placed. Her final gradient across the valve was 6 millimeters of mercury. Her mean LA pressure had come down to 10, and her V wave had come down to 18. So again, improvement in her mean LA pressures, improvement in her MR with a minimal increase in her transmitral gradient. She was observed in the hospital for 48 hours after the procedure and was seen at 1-month follow-up, NYHA class 1 symptoms now with dramatically improved dyspnea. So a couple of key learning points for us as a team when thinking about recurrent MR after MitraClip. This is a significant source of heart failure symptoms, morbidity, and mortality. And things that can herald this are going to be if you have flail leaflet, if you have residual post-procedural MR after the initial clip placement, and as the LA volume increases. Survival's improved regardless of how you fix this recurrent MR. And in this case, we chose a percutaneous option because of the patient's surgical risk, age, and frailty. In this case demonstrates that plugs are a potentially effective treatment for residual mitral regurgitation. I want to thank Dr. Goyle, Dr. Clucky, who were the operators on this case, and on whose behalf I'm able to present this today. Thank you.
Thank you very much. Very nice presentation. What a great outcome for the patient. I'm a surgeon, so perhaps you could enlighten me. How can you be sure that you put a plug there in between the clips that'll be stable? It seems amazing to me.
Yeah. So, you know, yeah, difficult question. What I'll say is that when you look at the literature, the most robust case reports and case series to support this are with the AVP2 plug. There's some data with septal occluders and VSD occluders. And in that case series with the septal and VSD occluders, upfront short-term outcomes were good, but there was a significant portion of dislodgement in the months to follow. And at least in the published literature with the AVP2 plug, that has not been the case. So I guess the answer to your question is we can't be certain, but at least from what we know, we don't think that risk is quite high. The other thing is that those 2 prior clips have been in for 3 years. So they're endothelialized and they're a little bit more stable than if the clips were put in at the time of the plug.
Yeah, and you know, in that regard, for a fantastic presentation, by the way, in that regard, the interventional cardiologists are similar to the surgeon, often wrong, never in doubt. So I think the question I have is around hemolysis. And you know, the description of doing plugs in between clips or clips and commissure, you know, has been described as you've stated. The issue with, you know, we don't see hemolysis with clip much is probably because, you know, the way it acts on the leaflets and the surface, the smooth surface. It's a little bit different with plugs. Yeah. You know, any consideration of hemolysis, how you deploy the plug to minimize the hemolysis, how do you watch for it? What was their consideration for hemolysis in this case?
Yeah, I think that, you know, when the patient was being thought of, she was very symptomatic going in. And so it was felt that something really had to be done to give her a better quality of life. And so when that residual MR was left, really the primary concern was addressing her dyspnea and dealing with what was going to come thereafter. I think to your point, we said we have a problem without a great solution otherwise, so let's go after it. She was monitored post-procedurally. Hemoglobin remained stable. Was not specifically monitored for hemolysis, but at least in 1 month follow-up, we haven't seen any evidence of it. But it's certainly something that complicates these procedures.
Yeah, good points. Great result there. Things that made me a little nervous on this case were
just one.
A few, but you know, I've also put plugs between clips and things like that. The mobility of the leaflets here bring up the concern for long-term dislodgement to be serious. So just keep an eye on that for sure. I think, and also the same thing with the hemolysis. I think plugs often work best when you go between a clip and a commissure. If it's in the middle of the valve, I think it works, but I have a little bit of pause there. There's not a lot of data to kind of make yourself feel better. One thing to consider, I don't know what your center's experience is, but you could also look at ElastiClip in this case, where you electrocauterize those leaflets off the posterior leaflet or the anterior leaflet, and then you can put in like a Tendyne. But that's a lot more complicated than what you did, which is good.
Thank you.
Very nice job, thank you.
Thanks.
Our next speaker will be Dr. Voudris to talk about pacemaker wire manipulation for tricuspid TEER. And thank you, all the speakers, for sticking to time. It's helps me get on my flight back to New York on time, that's for sure.
Perfect. Hi. I'm Dr. Voudris. I'm a former structural fellow over at MHI, and I'm happy to be presenting this case on behalf of the team at Minneapolis Heart Institute. I have no relevant disclosures, and our case is an 84-year-old female. She has symptomatic severe mitral regurgitation, torrential tricuspid regurgitation, heart failure with preserved ejection fraction, as well as a single-chamber pacemaker to which she's dependent. She's been having recurrent hospitalization for heart failure exacerbation despite being on all the goal-directed medical therapy. We opted to proceed with a MitraClip TEER with a placement of NT with reduction of her mitral regurgitation to mild. She did feel some small improvement in her symptoms, but almost close to a year later, she's still very symptomatic. She has remained in all the appropriate medication, and she's currently in NYHA Class 3. She's high surgical risk, so we originally decided to proceed with a right heart cath, try to make sure whether we can further volume optimize, and pretty much her blood pressure was 10, so she was kind of appropriately optimized. So we started working her up for a tricuspid intervention based on her torrential TR. These are the pictures from her transesophageal echocardiogram, and you can see there's clear evidence of torrential TR. There is a pacemaker lead that it's actually going through the tricuspid valve, and it seems to be interfering with her septal leaflet. You can see on the deep transgastric, there's a lot of motion that's primarily centrally as well in the anterior septal territory. This is a type 3B valve with 2 posterior leaflets, and primarily her regurgitation is originating in the anterior septal and central position and around the pacer lead. So a little bit more on the 3D views that confirms all the anterior septal location of the TR. And wherever we're looking at a patient for tricuspid intervention, we always look for the big 5 for success, and Galio and Dr. Hamid, that's courtesy, the slide is from Dr. Hamid, and she's touched a lot about it during this meeting. So we look at gaps, imaging, anatomy, leads, as well as anything else that might be interfering with their outcome. And the same way as for mitral TEER, for tricuspid TEER, we have yellow, green, and red. And going through it, for the gaps, we had appropriate gaps. Anatomy was a 3B, so it would be on the yellow range, but it would not be an exclusion. Looking at the lead, you do have a lead that's interfering with your septal leaflet, and it's actually in the area where we're planning on clipping, so it's definitely a red there. And imaging and other are all green. So primarily your clinical problem right now is what do you do with that lead that affects the ability to clip? And what we did is actually we decided to proceed with manipulation of the pacer lead. So the way we do it is we use an agilis. We opted to move this lead posteriorly since anterior septal was primarily the area we're going for, so we wanted to look for centralizing or move it as much posteriorly as we could. Whenever we do lead manipulations, we do it with TE to make sure that it's actually moving away from the area. And you can see here, by grasping the lead and moving it posteriorly, we were able to bring it more centrally, so that allowed to open up the anterior septal area, and that's where we placed our first XTW. And you do see there's still residual regurgitation that is a little more posterior and centrally to the previously placed clip. So we opted to go with a second XTW, again, anterior septal territory right next to the prior one. And this is after the second clip deployment. You can see significant reduction of her tricuspid regurgitation to mild to moderate. And you can see the lead in the picture to the right. You can see it's actually in the central position, right more on top of the two previously placed clips. We did use ICE to confirm clip enrollment as well as interaction with the pacer lead. And we could see that the lead was free. It was not entrapped in any of the clip arms. And that's the final step where we do the wire release. And you can see the wire being free and posterior to the other 2 clips that we've placed. Key learning points, previous pacemakers, they are a concern whenever we're doing tricuspid intervention. It's not an exclusion. You can try to see if wire manipulation can allow for opening or mobilization of the leaflet. It's very important to have a good echocardiographic evaluation as well as screening and a planning pre-procedurally. Galio and green, yellow, red zones are really important. And whenever you're doing pace wire manipulation, it should always be associated with TE imaging at the same time, so you can see how much pulling or whether you're moving anterior or posteriorly, how much is it affecting your grasping views, and how much is it causing you more shadowing, or is it opening up the opportunity for you? And thank you.
Jonathan?
I guess I'm the default. I have to be careful here because I don't want to criticize Paul's cases too much. Otherwise, I might not be asked back to the meeting. But great case. I think that's a very innovative technique. It also, I guess I'm curious if you entertain the idea of lead extraction. This obviously is a lot easier. I think in general, we all have found extraction doesn't really change the TR, and that's never really the goal. I think more it's just to get it out of the way, make the imaging easier. But I just wonder if you had thought about that.
So we always do, and that's a great question. We always do, like, we try to see whether we can mobilize it and see if, like, we can take it out of the way. Extraction does come with its own risks. Especially when they're older leads, you're coming with a risk of actually injuring the valve itself, and that would open, like, the option for a TTVR and going down that cascade. If we feel that there is enough redundance to the lead where you can easily, like, centralize it and take it out of the way, then we usually try it. We have extracted leads in the past, and it's one of the other strategies. So it's kind of case-to-case selection based on how much we can mobilize it and how much is it interfering with, like, the subvalvular apparatus. Does it affect the cords? So it's a lot of discussion.
Yeah, that's fair. It's also, it's going to be interesting once the Trisend comes out, because a lot of those cases were just entrapping behind the valve and the annulus, so we'll see what happens long term with that.
Yeah.
Yes, so let me ask you a question. So snaring the lead is, we used to snare a lot more than we do right now. Now we just go around them. If you want to snare posteriorly like you did, it's easy. You went and pull down. If you want to snare anteriorly, what would be your strategy? You go IG, but then it was slides on the catheter. You don't necessarily get it off the valve where you want to do. Any tricks about how you snare them?
So we have, and the team actually have like recently published a paper on, like, different options. It all comes down to how much, like, lead do you have and how much, like, lead manipulation. So we've tried, like, snaring it up and try to see if we can bring it anteriorly. If you have a lot of lead, you can try to loop it around the catheter and just push it away from the, like, either septally or towards, like, the AP commissure, which usually you're not going to go. And that's where the TE comes into play. So a lot of this, we'll try to do it before the actual procedure. So when you do your right heart cath, we'll do a general sedation, we'll do a TE as well as, like, wire manipulation and try to see which way we can, like, push it or move it. There are snares, as you said, that you can try to, like, push it up, like especially the end snares, like, they have multiple, like, so you try to push up the wire and hope that you can keep it anteriorly. So it's a trial and error primarily, and trying to see how much does it move.
Thank you.
Great case, thank you. Just a couple of comments, just want to get the input of our panel and maybe those in the audience that have any thoughts. I know Dr. Goyle is sitting here and some others, but we're hoping, we don't know, but we're hoping that TriClip will be commercial in the not too distant future. And many of us are familiar with the data from the Triluminate study, and we're thankful to all the investigators, including Jonathan and Paul and everyone, but very important data that we've learned about this space. We're going after quality of life improvement with TriClip, right? And those of us who practice in the community, we're communicating with referring physicians, some of whom obviously may not be cardiologists, but most of them are cardiologists. And then working with our surgical colleagues and making these interdisciplinary decisions, and also with our EP colleagues when we talk about lead extraction, lead repositioning. And now there's leadless dual chamber devices that are commercially available and that are being used as well, which I think is great because for the future of pacing, less tricuspid leaflet involvement. But how do you guys think we navigate these conversations with referring physicians, with our surgical colleagues, with obviously patients and their families when we talk about all these nuances? Is there a lead? Is it in the way? Is it not in the way? Should it be extracted? Who's going to do the extraction? What's the risk of the extraction? Will there be epicardial leads placed instead? And then after all that, oh, by the way, we're also going to clip your tricuspid valve. It's not going to necessarily help you live longer or keep you out of the hospital, but it may help you with your quality of life. I mean, it seems like it's a lot to talk about and to consider, all for symptomatic benefit. And so, I mean, I don't know if this is like a multi-part question, but really I'm just trying to trigger some conversation or those of us that are involved in TEER, because it's not like mitral TEER. It's a whole other animal with so many other nuances because of pacing.
I'll take a stab at it. You ask a lot of questions, but I think it's going to be like one of those best answer competition now. But I think, I mean, those are very, very, very good point. So a few things I would say is, definitely Tricuspid have expanded the heart team in ways that is above and beyond what has been historically done. Usually it's an interventional cardiologist and surgeon. With tricuspid, heart failure is involved, EP is involved in many of those decisions. So one thing is we have learned how to think about tricuspid disease as a team. Two is I really do not think that Triluminate is the final answer. I think it is the first answer in something that has been a black hole for us for a very long time. We still need long data from Triluminate. It is a little bit premature to say tricuspid does not only improve tricuspid TEER only improve quality of life, no mortality, no heart failure, because you might not see it at year 1, you might see it at year 2, you might see the benefit at year 3 and beyond. And 2 is it's also the first of many. There is another TEER trial undergoing. All of the TTVR trial are undergoing.
And the BRIGHT registry data as well.
And registry data. So I think that we will learn more as time goes. So I don't think it's the final answer. I think it's the first right answer, or the first answer in the right direction, however you want to say it. The last thing I would say is quality of life matters. It matters to the patients. It matters to their family. And we as an intervention community for the longest time, we've held ourselves to the hard outcomes of mortality. Honestly, with the age population that Triluminate enroll, and similar to all of the tricuspid trial, a lot of those patients just don't care about living longer. They just want to live better.
And I think I'll just quick, because I know we need to move on, but the thing that makes the sell easier, of course, if you tell a patient, I've got this procedure that potentially is going to make you feel better, most of them will say, I'll do it. I feel particularly okay doing that in TEER because it's so safe. The safety signal was very impressive in Triluminate. So we'll get more. The trial published only had the first half of the patients that have been enrolled. So great, let's move on. Next up is Daniel Johnsrud, who's going to talk about a hybrid treatment of a Dehisced bioprosthetic valve and a large pseudoaneurysm.
Hello, I'm Dan Johnsrud. As you said, I'm from Aurora St. Luke's in Milwaukee, just finished structural fellowship there. Also with this case, Dr. Jain, our structural imager, Dr. Weiss, surgeon, and Dr. Bajwa, the interventional cardiologist. So no disclosures except for the fact that unfortunately I was not scrubbed in on this case. This case happened when I was a general fellow interested in going into interventional, and I was kind of asked, write this up, and I'm finally getting around to at least presenting it somewhere. So the case presentation, 68-year-old man with refractory heart failure. His pertinent history, he had CAD with cabin in 2007, a SAVR in 2016, I'm not sure the valve, and then urgent redo 2017 with a 21 magna and a patch repair for an LV outflow tract, a fistula and abscess, and that was in the setting of endocarditis. He's had 3 heart failure hospitalizations in the last 6 months at outside hospitals, but in our same system. He's now kind of refractory, and he's transitioned to our hospital with lactate up, LFTs up, creatinine up. They can't diurese him. They did an echo, showed EF around 40%, mild, they said mild AI, moderate to severe MR, moderate to severe TR, but they weren't really sure what's going on, so they said let's just transfer him to St. Luke's, our kind of tertiary center, and see what's going on. So we had decided to get a TEE as one of the first things with his history. As you can see here, there is basically a pseudoaneurysm connecting from like the aorta mitral curtain area. And on the second shot, there's actually kind of a dehisced area with flow going from the aorta into the pseudoaneurysm and then down into the LV. They also thought there's mild to moderate transvalvular regurgitation as well. And so here's a CT showing different views of this pseudoaneurysm. The imaging was fairly difficult even with all these modalities for us, but we felt the main connection is kind of subvalvular from this bioprosthesis. So the clinical challenge, we thought a 4-time sternotomy was extremely high. The same surgeon who did his 2017 surgery is in our heart team involved with this case too. He has a large paravalvular leak through the large pseudo and mild to moderate transvalvular leak in an unstable valve. We have advanced heart failure on board. They say he's not a candidate for transplant. He's 68. We transplanted up to 70, but for various reasons he wasn't a candidate. They thought his RV wasn't good enough to do VAD, LVAD. I'm not sure if that's truly the case, but that was how they felt at the time. So we thought hybrid surgical transcatheter approach for valve-in-valve, TAVR plugging to plug the pseudoaneurysm connection. Now, I think something to note for this, this is going to be a very high-risk case. Patient was aware it's a very high risk. Number 2, if we don't do anything, he's not going to survive very long, we don't think. And number 3, kind of this is a case we felt as a program could take on the risk of doing this case. So we brought him to the cath lab. As you can see in the picture on the left, we have transapical access from the surgeon. We're going to put the certitude sheath there, and through that, we usually go with the 6 French 23 centimeter sheath, a 6 French multi-purpose in the pseudoaneurysm on the left. And you can see that filling contrast there, quite a bit leaking back into the LV. And then we did have a pigtail in the aorta as well. As you can see, there is quite a bit of AI from that shot too. You don't always need a pigtail for these kind of cases, but in this case and other risks, like more high risk cases, we usually do have just kind of a secondary access just in case we need another access. And it does help with localization too. So we place 18 millimeter AVP2 from the apical approach. You can see that on the left here. And then there is still quite a bit of leak, it seems less, but at that point, they decided to go ahead and go in with the valve. So you can see here on the left, coming up with the valve, you can see that it is a little, like I said, unstable. It's moving when it's deployed, but there's the deployment there. Looking at TE after deployment, they felt there's still too much leak. You can see that potential space right there on the non-color. So they went back in, crossed that again with a glide wire multi-purpose, brought the 6 French sheath in, and then put another 10 millimeter AVP2 in. And then you can see here that it looks more stable. There is still leak there, and like I said, I wasn't in this case, but coming from a structural urinalysis, this would make me a little worried about hemolysis, but like I said, I wasn't in the case, and I'm the fellow. But anyways, they decided that they got a pretty good result. Let's see how he does. So he was eventually weaned off pressors. He was in the hospital for quite a few more days, but was able to be weaned off pressors, discharged. 6-month CT, the pseudoaneurysm was unchanged in size. It had not thrombosed, but it was unchanged in size. He had mild to moderate AI, and EF had improved from 40% back to 50%. LV size is normal, and now he is 2 years post-procedure with no heart failure hospitalizations. Here's his 1-year TE. I'm sure the leak would look worse with TE, but on TTE, it doesn't look too bad. Mild to moderate is what the echo readers called it. So key learning opportunities is surgical apical access can provide ideal trajectory for aortic subvalvular procedures, especially these paravalvular procedures. Like as I said, large bore is facilitated with no bypass or sternotomy. And then lastly, with a caveat, you really have to be careful with hemolysis, but residual mild to moderate AI may be clinically acceptable if you don't have significant hemolysis. Thank you.
I think William is willing to miss his flight to discuss this case.
That's a great presentation. I mean, that's obviously a terrible problem to have. and I don't think, I mean, I'm faced with a third-time redo for something similar, and no one looks forward to something like that. My question to you is, you know, if for whatever reason they couldn't have a thoracotomy, are there other ways you can access that from a transcatheter point of view? I mean, this patient was young enough and probably could handle it, but you know, we sometimes see patients where doing even a mini thoracotomy and going through the apex might be too much for them. Did you or your team consider what other potential approaches if you know, any kind of surgery was off the table?
Like I said, for this case, I wasn't in the procedure itself. I think they felt that this would be very difficult to plug from another trajectory than from the apical. One thing I was thinking would just maybe a 6 French from the apex and then go from the groin for the valve, but in that case, if you embolize the surgical valve into the LV, there's really nothing you can do. Maybe if you embolize it into the aorta, he probably still won't do well, but you might be able to bail him out. But retrograde from the aorta would be extremely difficult, I think, to plug. I don't think that would be possible. Going from the transeptal approach, kind of tenting open the mitral valve, that's all going to be a challenging situation too. So I think this guy was young enough, and the way his echo looked, the surgeons felt like he can handle a surgical transapical access. But other routes of access are not very easy for this case, I don't think.
I'm glad you guys appreciate it, because you know, when we have cardiology fellows come to the OR, they often remark to me that they didn't realize before coming to the OR how heinous multi-redos can be. And so credit to your team for you know, thinking outside the box and getting this guy through. Go ahead.
Yeah, that's another thing. I think Ruby coils maybe was an option. They decided not to do that for whatever reason, but for me, trying to fill that up with Ruby coils, I don't think it had another good connection to the aorta. You worry about embolization. You don't want those embolizing everywhere, but that could be another option instead of trying another plug.
So let's say this patient seek you out and say, oh, you were a fellow in my case 2 years ago, I still have that leak, and find you and come and see you. What would you do? I mean, he's young, still have a significant flow. Would you try again? Do you think that, you know, the results that you got, he've done well for 2 years, just leave him alone? What do you think the strategy for this patient moving forward? It's not uncommon that we tackle lesions like that and we don't completely eliminate it.
So I think as long as his LV size is okay, his LV is not dilating, and he's not in class 3 kind of heart failure situation, and we're not seeing hemolysis, I would kind of tell him this has been stable, we can watch this. Us doing anything about this is going to hurt you more than this leak will hurt you. But if things are trending worse, I might consider like a 6 French transapical access if the heart team was on board with that, and seeing if you can do something again. Can you get a wire in there, put another plug? Could we do coils now if it's not thrombosed? And those you could close it out on the way out with the plug, but I would be hesitant to intervene based on the flow as long as clinically everything else is stable.
All right, thank you so much. Well, last but not least, we have the final presentation from Dr. No, that one couldn't make it. From Dr. Foth, discussing structural mitral valve vegetation, Angiovac aspiration. I think, William, that was one of your favorite topics, isn't it? Yeah.
Hi, everyone. Thanks for having me. I'm happy to present our case today from our cath lab with Dr. Mohammed Hamada, who's the first operator in this case. I have no disclosure. We had a 36-year-old male with known history of IV drug use who was brought to our hospital with altered mental status. He was found to be severely septic and bacteremic with Staph aureus. He required intubation for airway protection, and he was started immediately on IV antibiotics. CT head showed multifocal subacute infarcts. CT abdomen pelvis showed renal infarcts and splenic infarcts concerning for systemic thromboembolism. Transthoracic echocardiogram was done and showed normal LV and RV functions. However, it showed large vegetation on the posterior leaflet of the mitral valve, as we can see here, causing severe mitral regurgitation. Subsequently, we performed the transesophageal echocardiogram that showed that confirmed the fungating large mass on the posterior leaflet, causing perforation of the leaflet and the severe mitral regurgitation, as we can see here. We can see how large the vegetation here in these views on the TEE. This is a surgical view of the mitral valve showing the vegetation. So now we have a mitral valve infective endocarditis with systemic thromboembolism. And so what are our treatment options here? So first would be medical therapy. However, it will not be sufficient in our case given the size of the vegetation, and also it will not prevent the likelihood of having recurrent embolization. Surgical removal would be an ideal approach here in this case because we can fix the mitral valve along with removing the vegetation. However, the patient have a high risk for hemorrhagic conversion of ischemic stroke, and also he needs to complete drug rehab first before he gets to the surgery. Transcatheter removal is another option. However, it's only approved for right-sided infective endocarditis, and there is only limited data on the left side used. There is only a few case reports published, and this approach also carries risk of embolization during the procedure and also will not address the severe mitral regurgitation that we have. Multidisciplinary approach was followed here. The patient was deemed not a surgical candidate given the high hemorrhagic conversion risk if he were to be placed on the bypass machine. Our team offered an off-label Angiovac aspiration to minimize the risk of systemic embolism and to give time for antibiotics to clear the bacteremia, and also give time to the patient to go to the rehab and as a bridge for the definitive surgical treatment. Family was involved in the case, and we were all on the same page, so we decided to proceed with the procedure. So we got bilateral radial accesses, and bilateral sentinel devices were placed. IV heparin was given with ACT between 250 and 300. We got a right femoral vein access with a 26 French dry seal sheath, and was parked in the inferior vena cava, and we also got a left femoral artery access with a 15 French return cannula. We performed the transseptal puncture. We chose the superior and posterior part of the septum, as we do for MitraClip, to give us height for the device and also to prevent contact with the vegetation. Then we advanced a stiff wire, Amplatz wire, to the left upper pulmonary vein, and we started deploying our Angiovac system. It was a 22 French C180 cannula that was advanced over 10 by 40 millimeter peripheral balloon to the right atrium. Balloon septostomy was performed, and the Angiovac system was advanced to the left atrium with balloon-assisted tracking technique. Funnel was exposed, and we started a slow flow of the suction to minimize risk of embolization. Under TE guidance, as we can see here, we lined up the Angiovac cannula over the vegetation, and we increased the flow to 4 liters per minute, and we started getting the materials back. We can see here how big the vegetation was. We were able to achieve about 90% debulking of the vegetation. This is the post-procedure TE. We can only see residual vegetation here and no change to the MR. The pathological report only showed fibronopural and debris with no valvular tissues identified. Post-procedure was uneventful, and the patient was discharged 10 days after. And this is him 30 days later seeing Dr. Hamada in the clinic. He completed his antibiotic course. He recovered most of his neurological functions. He can walk, talk, and run with only without significant impairment. He's attending rehab now, and this is as a bridge to his surgery. So our key points here is that Angiovac aspiration of mitral valve vegetation could be a potentially safe and feasible options for patients who are not surgical candidates.
Excellent, nice job. It's good to see that, with guys coming up able to plug abscess, pseudoaneurysms, and angiovac, these big vegetations. I'm pretty happy to send some of these cases over to you guys, so I don't have to deal with them. It's interesting, often I found the neurologists, the classic teaching in cardiac surgery is, 1 week after a big ischemic stroke and 2 weeks after a hemorrhagic stroke. And, I found neurologists invariably, if they've been stable after a week, they'll often say they're okay to have surgery and that the risk of hemorrhagic transformation is not high. Obviously, your patient had a substantial one. So, I mean, if someone like that was kind of stable and they maybe cleared their cultures but still had this really big vegetation, would you push the surgeons to operate more if they were stable and not in florid heart failure? Because, I must admit, I don't think I know any cardiologists. Maybe you got to send them your way, but don't know many cardiologists that would angiovac something like that. And really, most of my colleagues would push for surgery and try to get the patient through a 7 to 10 day period and make sure they were neurologically okay. How urgent do you think it was from a heart failure point of view?
That's an excellent question. So it was actually a multidisciplinary team, including the neurology team as well. And given the extensive infarcts in his brain, the risk of hemorrhagic conversion is still high, even within a couple of weeks from the presentation. So that's why the only option that we had is. So surgery was was a no, but the other option would be just medical therapy at that point, but will not be sufficient. So that's why we offered our procedure here.
Yeah, certainly with such a mobile and the staff as the organism, it's kind of hard to justify not doing anything at all. So I have to commend you on doing something. And I mean, are you concerned when you do something like that that you'll make the MR worse, because you're doing a lot to the leaflet, and having been there, when you pluck it away at these vegetations, often the leaflet just falls apart. Yeah. And so, I mean, as a surgeon, I often think about bailout. I mean, if he had torrential MR afterwards, what was your kind of thinking?
So that was one of the big concerns that we had, and in such cases, our goal here was just at least decrease the burden of the vegetation, because it was a very large vegetation causing embolization. So we were not greedy in debulking the vegetation, and we followed the techniques so that we were not. It was a contact-free to the vegetation as much as we can, so that we don't dislodge and causing embolization, and also. It was under TE guidance, so that we prevent getting any damage to the mitral valve itself. And again, it was the MR was severe to start with. It was almost torrential TR, MR. I'm sorry. So I think we were already there. I think it would have been worse than what we had, but. And the good thing is that on our pathology report, there was no any valvular tissue identified. It was only fibrinopurulent materials.
If it gets much worse, you have to force them to operate. So.
Yeah, exactly.
We're down to the last couple of minutes, but Rahul, I want to ask you a question. You said a comment earlier that I took to heart, saying, this is off-label use. They will never allow me to do it in my institution. What do you think? I mean, Angiovac has been used more and more, tricuspid, and now this case, mitral vegetation. What do you think the pathway forward for this to get it to FDA approval? I mean, a lot of them are used as surgical contraindications. What do we do? How do we get it there?
Yeah. So let me before I answer your question, let me just clarify one thing. Angiovac as a device is FDA approved, but the use of Angiovac for what you used it for is not FDA approved.
Correct.
Okay. So, look, I think that there are certain hospitals where something like this can never be done, okay? And this is not like TAVR, which is a commodity and is being done, you know, at most centers or many centers. This is probably something that will be done at places that have, for lack of a better phrase, have an appetite for something like this. And that doesn't necessarily just mean academic centers. There are probably many hospitals that are non-academic hospitals technically, but that have resources to do this. But I think the pathway, I mean, this is just an off-the-cuff answer, but for anything that is being considered in a hospital that is not FDA approved for that indication, but is commercially available, you can do it. It's not completely experimental. I think that institutions probably should have some sort of a written up algorithm that has been approved by the institutional administration or perhaps by peer review committee, so that on a case-by-case basis, if a case comes along where the hospital has resources to do it and there is administrative political support to do it, that a brave physician, he or she, can do this within the confines of the institutional bylaws. That's the only pathway that I see for something that is outside of a clinical trial and is being used for essentially palliation type purposes, which is really what we're doing here. Although you may have gotten such a good result that the patient, you know, may live longer, but that's not the intention. But this is going to happen at kind of referral centers that, whether they're non-academic or academic, but centers that have access to Angiovac, have access to obviously open heart programs and surgeons and cardiologists that are facile with this, that are willing to do it. But probably an institutional-based algorithm until the time comes that someone, and I don't know if this would ever happen for this particular type of scenario, but until the time comes that someone does some sort of a clinical study that can be put in front of the FDA. And I don't know, does anyone know if that's happened with Angiovac with regards to mitral or tricuspid?
So there is a registry that our institution is part of. There is only less than 100 cases in the nation. I think we're still working on getting more numbers, and then this data will be published hopefully soon. But again, this is not a replacement for mitral valve
of course,
replacement.
Right.
And in a situation like this with a young patient and surgery was no-go, I think that was the only option. I don't know if you, if there would be like a different approach that you would have followed in such cases, or.
No, I mean, this is, you know, you didn't have a lot of options here, right? And right. Yeah. Yes. Right. Yeah, the health system can still get paid by using that loophole, however you want to call it, but the physician won't get paid.
Well, we're at time. Thank you, Ayman. Wonderful presentation. Thank you all for